My name is Kirk Geyer, and I'm the General Manager of Biomedica Diagnostics. On behalf of the Biomedica team, it's my pleasure to welcome you to our series of scientific discussions with key opinion leaders in the field of thrombosis and hemostasis. I hope that you will find these topics both informative and stimulating. At the end of each video, you will find an email address where you may send us your comments and opinions. We would also appreciate your suggestions for future topics that may interest you. Now, on behalf of Biomedica, please enjoy.
Hello and welcome to COEG Conversations, an educational series sponsored by Biomedica Diagnostics of Windsor, Nova Scotia, Canada. Our topic for this series is immune thrombocytopenic purpura, ITP, and the inherited platelet function disorders. I'm George Fritzma, faculty of the University of Alabama at Birmingham Division of Laboratory Medicine and proprietor of the Fritzma Factor, your interactive hemostasis resource. It's my privilege to introduce our guest, Dr. Michele Lambert. Dr. Lambert received her undergraduate degree in biology from Rensselaer Polytechnic Institute and attended medical school at Rutgers University. She did her residency in pediatrics at St. Christopher's Hospital for Children in Philadelphia, followed by a year as chief resident and then hematology oncology fellow at the Children's Hospital of Philadelphia, often shortened to CHOP. She is now an associate professor of pediatrics in the Perelman School of Medicine at the University of Pennsylvania and a pediatric hematologist at CHOP, where she is the clinical director of the Special Coagulation Laboratory and co-director of the Frontier Program in Immune Dysregulation, as well as the director of the CHOP Pediatric Platelet Disorder Program. Her particular clinical interest is in the inherited and acquired platelet disorders and in the interplay between genetics and disease. Her current research focuses on understanding the role of genetics in this space. She is a member of the ClinGen Hemostasis and Thrombosis Clinical Domain Working Group and a co-chair of the ClinGen Hemostasis and Thrombosis Gene Curation Expert Panel, as well as the past chair of the Pediatric ITP Consortium of North America. By understanding the drivers of differences in biology in platelet disorders, Dr. Lambert hopes to develop targeted therapies to improve outcomes. We begin this third conversation with a discussion of the inherited platelet function disorders. Welcome back once again, Dr. Lambert, and let's begin with kind of an overall outline of the classifications of the inherited disorders.
Yeah, so the inherited platelet disorders are a very heterogeneous group of platelet disorders or of bleeding or non-bleeding disorders. I break them up in a couple of different ways depending on how I'm thinking about them and what the patient came to me with. So I think about the inherited platelet disorders as either thrombocytopenic or non-thrombocytopenic, and then you can go down different pathways within that, or a platelet function disorder or not related to platelet function, and you can go down different pathways within that as well, because you may have a inherited platelet disorder that is a thrombocytopenia and a platelet function disorder, or that is a thrombocytopenia without platelet dysfunction, or a platelet dysfunction without thrombocytopenia. And so I usually try to kind of classify my patient. Are they bleeding or not bleeding? And do they have thrombocytopenia or not thrombocytopenia? And then try to figure out, which way am I going within that classification. If I'm just thinking about the broad world of platelet disorders, then that's a whole separate way of thinking about things altogether, because there are so many platelet disorders that have been described, and there are new ones that are being described every couple of months. It feels like there's always a new report in blood or in blood advances or in JTH. There's something that's coming out that says this new gene is associated with thrombocytopenia or with platelet dysfunction or both. And so rather than trying to remember every gene that has been associated with platelet disorders, I have started trying to, and lots of other people have done this as well, to categorize the platelet disorders by mechanism of action. And I think that that's a very helpful way to think about the inherited platelet disorders when I'm trying to think about pathophysiology, when I'm getting down to either trying to actually make the diagnosis in a patient or put together different types of laboratory testing or variable parts of the family or patient history in order to try to come to what's happening in my patient. And I will think about the different categories of platelet dysfunction based on the different parts of the platelet or megakaryocyte that might go wrong in order to think about how to categorize those different molecular mechanisms for disease. I actually do have a figure for that. This is taken from a very nice review that was actually in the ASH hematology education book. And you can see that a list of different genes that are involved. For example, if you have a defect in one of the transcription factors or splice factors. And then, different diseases that have been characterized to cause, and most of these will cause thrombocytopenias. Or if you have a defect in an ion channel, these will also usually cause thrombocytopenia and platelet dysfunction. And that makes sense because if your ion channel is not functioning properly, you're going to have problems in both the megakaryocyte and the platelet. Cytoskeletal defects tend to give you macrothrombocytopenia. So the platelets are big and often actually not too dysfunctional, or you have small platelets. So Wiskott-Aldrich, WIB-F1, FYB, and ARPC1B, these are micro thrombocytopenias. So there's now not just Wiskott-Aldrich that gives you small platelets, but we've now identified several different genes that cause small platelets. They're all related in some way or another to the cytoskeleton as well. And then these cause macrothrombocytopenia on the top here. And then, of course, we have the canonical platelet disorder of Bernard-Soulier with defects in GP1B, alpha, beta, and GP9, or Glanzman with integrin alpha 2B and beta 3, so platelet receptor and signaling problems, but there are other platelet receptor signaling problems that have been described, and then problems with platelet metabolism that can give you thrombocytopenia as well, and problems within the mitochondria of platelets, and then platelet granule defects that can cause problems within your platelets as well. So NBL2, of course, is the gray platelet gene, and then these others can cause also platelet alpha granule and dense granule defects. And then these disorders are problems with a platelet lifespan. So GNE, SLC, 35A1, and GALE all decrease the lifespan of platelets and result in increased platelet clearance because of changes in sialylation of the platelets. And so the platelets don't last as long in circulation. So all different mechanisms by which you end up with inherited thrombocytopenias plus or minus changes in platelet function. And then we do have other, see, the list is just getting longer and longer, but other platelet disorders that might be just associated with platelet function. And so in some of these disorders, you can have, for example, alterations in CalDAG-F or Kindlin and Talin bind.
Yeah.
So you can get defects in signaling that result in, for example, in CalDAG-F, where you have a significant platelet disorder and decreased aggregation, other signaling defects in some of the G proteins where you just have platelet dysfunction without thrombocytopenia. We have the dense granule defects, for example, Hermansky-Pudlak and Chediak-Higashi, which are classic platelet dense granule disorders, but those are syndromic and have lots of other problems as well. But we know now lots of different genes that can cause either platelet dysfunction or thrombocytopenia, and many of them are associated with a platelet defect and other problems as well. And so I think it's not unusual for me to see a patient and say, do they have just a platelet problem or more than a platelet problem, and then think about them that way.
Well, I think about the days not very long ago when all we talked about were the membrane disorders, maybe storage pool, and then we might think of something called platelet activation, but we really didn't know what we were saying at the time. So this is a great deal of growth. Talk a little bit about the let's call it the primary lab tests that you would use. How do you start out in, say, just a standard, like a academic medical center? Then they can do some aggregometry and that's about it. Where do we start?
So typically, if I have a patient who's bleeding, one of the first things I'll do is platelet function testing and try to get a sense of how well are those platelets working. And I'll want to assess platelet responses. And in a small child, I probably also will try to get flow cytometry, maybe even before I do for platelet receptor densities, maybe even before I do platelet function.
Mm.
Because I'm working with small children, blood volumes are a limitation, and doing traditional LTA requires like 30 mLs of blood, or light transmission aggregometry is because we use PR, platelet-rich plasma, for that requires a lot of blood. It's hard to do it in a very small baby, but if I'm looking for platelet receptor density, I only need a tiny amount of blood by flow cytometry to look for the platelet receptors to make sure that if I'm worried about Landsman or Bernard-Soulier, that they have those two receptors on the surface of their platelets.
I've always advocated for whole blood Lumi aggregometry as being the best way to do it. And of course, I know now I'm going to be at a meeting in a couple of weeks with people who just swear by LTA. So which do you prefer? And if you're not at the meeting, then we can't get into any trouble here.
Well, I fully admit that we do whole blood Lumi, impedance Lumi aggregometry here at our institution. And part of the reason that we made the switch is actually the blood requirement. So I can do it with a lot less blood because I don't need to make PRP. That also means that I'm not introducing spinning platelets prior to like in the processing of the sample. So I'm not activating the platelets prior to doing my testing, or at least taking the chance that I will. Because I have enough trouble getting the specimen without activating it because I'm using needles in kids that are already smaller than the recommended needle size. So I think I like to use the whole blood impedance Lumi aggregometry. I also think I'm a little bit less likely to pick up the things that aren't clinically relevant because that I think it's less likely to give me a spuriously abnormal result. We get in our kids, we get a lot of normals. And I think that's a good thing. I think I should be getting mostly normal testing. And so most of our kids, when we do the testing, turn out normal.
In one of the papers that I was looking at, people were still using the bleeding time. Do you ever use the bleeding time?
No, I don't. I think it's really hard to standardize the bleeding time, and especially in pediatrics. So I do have the perspective of coming from a pediatric institution. So, but it's real hard to hold that small child still for the bleeding time. And so, but even just standardizing it in adults, I just think it's such a difficult test to do well, and the people who knew how to do it are there's not many of them anymore, honestly. Most of my people in phlebotomy have never heard of one and don't know how to do it.
We tried to stop bleeding times at our institution back in the late 1990s, and the lab refused to do them anymore. All that happened was they all went underground. Go to all the nursing stations, and they had one of those devices and they were using it, which made them even less effective.
Standardized. Yeah.
Right. So anyway, well, I was curious because I'm still seeing people using them, and I've always talked about them, and I used to let students practice on me. I've got enough scars on my arm that the Red Cross looks kind of worried when they see me.
Yeah, I just it's such a hard test to really be sure that, I mean, that you're definitely going the same depth every time, that you're making the same length cut every time, that you do I just feel like even somebody who's really experienced can very easily not be consistent.
Yeah, exactly. Well, the key thing seems to be moving to the molecular testing, and I know you've developed some molecular screening panels. So tell us about that.
I actually think you need the functional testing even when you have the molecular testing, but
Mhm.
um, but I love my molecular testing too. So people who know me know that I have a bias. But I like to use them both. The molecular testing that I typically will do is a panel that looks at the known established genes that are associated
Yeah.
with the inherited platelet disorders. This is for a couple of reasons. First of all, that way I don't have to worry so much about counseling for unintended findings. I don't necessarily want to have to counsel the families about things that I wasn't looking for. And so this way I can just talk to them about the things that we're looking for, and really kind of keep the conversation about the platelet disorders. Because things like RUNX1 and ETB6 though are still on the panels, we do have to talk about cancer predisposition, which makes it a long enough conversation anyway. And so I think those conversations take time, and you need to make sure that you have the right people having those conversations. So if you don't have a genetic counselor or access to genetic counseling, I think it's really difficult to do that kind of molecular testing well. And I think it's important to make sure that the families have access to that kind of counseling around that testing. But I do think panel testing is the way to go. I don't think it makes a ton of sense outside of a research setting to be doing the more expanded testing. And the reason I think the functional testing is important is we still get a lot of variants of uncertain significance, meaning it's a gene that I know is important in platelet function, but this variant has never been reported before, and I don't know whether it actually affects platelet, protein function. And so then how do I put it into the right bucket of benign or pathogenic? well, now I need the platelet function. I need to know, well, does this patient actually have a defect that is consistent with a variant in this gene? And, if they have a GP9 variant, do they have decreased expression of GP9 by flow cytometry? Do they have abnormal ristocetin binding on platelet function testing? Because ristocetin agglutination, because otherwise that GP9 variant might not be relevant. It might be a totally benign variant. And so I think it's important to have both the functional and the molecular testing, and to be able to have somebody who can help you interpret both. You need to have that kind of expertise available if you're going to be sending that testing. And if not, then the patient probably should go someplace where they can get that kind of counseling and interpretation to establish a diagnosis and then come back to wherever they need to be.
2 questions related to that. Number one is, in doing the molecular testing, are there 2 or 3 conditions that pop up most often? And secondly, how much danger is there of a misdiagnosis?
So the danger of misdiagnosis, I'll answer first. The danger of misdiagnosis is over-interpreting variants of uncertain significance.
Mhm.
Those truly are unknowns. And so you can very easily tell somebody, for example, you get a variant of uncertain significance in RUNX1, which could potentially be a cancer predisposition, but really we don't know what a VUS is. And if that VUS is benign, they don't have a RUNX1 problem. And so it's really important, if you're going to talk about that RUNX1 VUS with the family, that you make that very clear. This could very well be nothing. And we need to figure out whether this is relevant or not. A lot of the commercial labs don't report VUSs. And so, and that's the reason, is that we just don't know what a VUS is, if it's benign, and it can do harm if you start, doing bone marrows on a patient because they have a benign variant, or what will turn out to be a benign variant in a gene. So a VUS is truly unknown, and it really doesn't make sense to start treating the patient like that is the answer until you actually know that it is the answer. So that's the danger and the pitfall. And now I forgot what the first part of that question was.
Asking what turns up the most often?
Oh, I think for us on our panel, we found quite a few. MYH9, RUNX1 comes up often as a deletion, like a microdeletion in the gene. And in the thrombocytopenias, I would say, and tubulin or actinin mutations come up quite a bit, actually. I have been surprised at how often those are the reason for the macrothrombocytopenia, even in a patient where I really wasn't expecting to find anything.
Wow, and all we do in medical school is talk about Bernard Soulier and Glanzmann's, and that's about as far, or maybe the NYH, but that's about it. Let's see, a couple more quick ones. First of all, I have a friend whose platelet count is always right around 90,000. Every time he has a CBC, he gets worried and calls me up and finds out. And I say, well, it's, that's just you. It's probably nothing. Is that pretty much how you would handle somebody like that? I think that's not too unusual.
Yeah, I mean, I think it depends. For me, I'm a pediatrician, so the patient I'm most likely to see is like a 5-year-old whose platelet count is 90,000.
Yeah.
And in that patient, especially if there's no family history, it's a little bit harder for me to sort of do nothing and not do a little bit of workup and just like try to make sure that that person's really going to be okay. But if I had a family history, dad has a platelet count of 90,000 or 100,000 or 80,000, ma or grandpa has a platelet count in that same range and neither of them have ever had any bleeding, then I might not do any more workup on that child either. And then we might offer molecular testing for curiosity's sake for the family, but I don't even know that in the absence of any associated other medical findings in that family, that we would necessarily say that it's incredibly important. If there's no associated hematologic malignancy and in the family, and there's no hearing loss, renal disease, cataracts, liver disease, or solid tumors. Mostly because if there's any of that kind of history in the family, then we want to make sure that we're not missing one of the other platelet disorders, and we would want to do molecular testing. But if none of that's in the family, then I'm like, yeah, you have an inherited thrombocytopenia. We could try to figure it out if you want us to.
Yeah, that's what I try to say to my friend as well. And one last thing, this really has more to do with adults, I suppose, than anything else. But we do a lot of testing for what used to be called aspirin resistance, clopidogrel resistance, and at UAB we've got a lot of LVAD patients, and they come in, I think, monthly for a complete aggregometry test, and really looking for whether the clopidogrel is working or not. Do you do any of that sort of work in your lab? And is there anything you would want to, are those serious concerns, is what I want to ask.
Yeah, I mean, so pediatric center, but we do have patients who are on antiplatelet therapy because of their congenital heart disease. They have a stent, or they're on anticoagulation because they have a valve in place or things like that. So we certainly do monitoring of either anticoagulation or antiplatelet therapy in patients. I struggle with, particularly in our pediatric population, what to do with that results of that testing, because we do actually have Verify Now, and we do platelet tag with platelet mapping, but none of those are fully validated in pediatric populations. And so I am always a little bit unsure of exactly what to do with the numbers that I get. But we use the adults sort of guidelines and make changes in doses based on that, based on published literature in other pediatric populations, mostly the congenital heart disease population. But it is, and so from that experience, and having read the adult literature, I think it's hard to know what to do with that. The important thing is outcomes, right? And I think most of the data doesn't suggest that we can predict what the outcome is going to be, whether or not you demonstrate resistance to antiplatelet therapy on, patients who are resistant to antiplatelet therapy have worse outcomes, but overcoming that resistance in the lab by increasing doses doesn't necessarily improve the outcomes, but does increase bleeding. I think that's what most of the adult literature shows. So it's hard to know what to do with those patients.
That's really interesting, because there's been an awful lot of emphasis placed on those things, and a lot of testing that's gone on. So that really is that's an area that is just not really clear to all of us.
Yeah, I think so. And I think it's an area of active, ongoing investigation. I hope we figure it out. And then I suspect that data is all going to try to get extrapolated to pediatrics, whether or not it's fully relevant or not.
An awful lot of what happens in pediatrics is kind of based on adult information, unfortunately. But
we're getting a little better at doing our own trials, but it's hard sometimes. So,
well, anything else you'd like to say about the inherited platelet disorders? This is a really fascinating area.
No, I think there's lots of work still to be done. I'm so grateful to all the people who have worked so hard in this area and have published so many amazing, incredible studies. and to all the people that I work with now to help to try to define which variants are relevant and which ones aren't. There's a large multinational effort that is ongoing to try to continue to do a better job of really identifying what's relevant and what's not. And I think that's really important work. And I'm grateful to all those people who are doing that work.
And you're in the middle of it. Well, thank you. This concludes our third and final conversation. And Dr. Lambert, again, thank you for your expertise. We encourage participant questions and comments, and there's a link on the Biomedica Diagnostics website for you to download a transcript of today's talk, which you can look at while you're attending the video, and you can also forward your questions or comments. Thanks again to Biomedica Diagnostics for sponsoring COE Conversations, and thank you for participating.